Welcome all. This presentation will highlight a mind map around the 6 common signs and symptoms of neurological conditions. The sensory system involves how the brain receives, processes, and interprets sensory information from an external environment. Sensory receptors around the body aids in the detection of changes in temperature, touch, pain, vibration, proprioception, etc. In addition, the spinal cord and areas of the brain such as the parietal lobe and suprasensory cortex function in the processing and analyzing feedback from sensory information. Therefore, if sensory receptors or pathways for electrical signals go through degeneration or retain an injury, sensory feedback is impaired, which can lead to sensations of pins and needles, numbness, hypersensitivity, or loss of proprioception. These impairments interfere with the spinal cord and brain's ability to process external environments and provide feedback of movements. Common sensory impairments include difficulty in fine and gross motor coordination, as there can be decreases in tactile feedback, abnormal balance and gait as proprioception decreases, and greater difficulty in cognitive learning on how to perform new skills that require motor coordination. Treatment strategies focus on how to improve individuals' ADLs, quality of life, motor function, and small improvements in perception. Strategies such as hands-on demonstration of the task with utilizing mirrors for visual feedback, as well as rehabilitation and sensitization training, has been shown to aid in individuals with sensory loss. Cognitive function refers to the brain's ability to process, sort, and retrieve information, which correlates with attention, memory, problem-solving, orientation, and consciousness. These functions are regulated within the frontal lobe, limbic system, and temporal lobe. Depending on where damage or degeneration is sustained, different impairments will arise, as damage to the frontal lobe will result in poorer judgment, disorganized thinking, and impulsivity. Damage to the limbic system can cause emotional instability and difficulty in forming new memories, and damage to the temporal lobe can lead to memory loss or difficulty understanding language. Cognitive function can be disrupted due to stroke, Alzheimer's, or a brain injury, which can result in the loss of neurons, information atrophy, specifically grey matter, or imbalances in neurotransmitters. This can lead to difficulties in completing ADLs, as individuals may become easily distracted, poor memory in understanding how to complete a task, or inaccurate planning and sequencing of activities. Treatment for cognitive dysfunction includes mental practice or neuropsychology. Additional strategies may include providing visual or verbal cues to remind the individual, such as alarm or bright-colored paper, to regain attention. Additionally, perceptual function focuses on the brain's ability to process and interpret sensory information, with an associated problem being difficulty in body awareness. Perceptual function utilizes the occipital lobe for visual processing and parietal lobe, which processes sensory information such as touch, temperature, pain, and the temporal lobe. If there are declines in perceptual function from a stroke, brain injury, or degeneration diseases, it can disturb pathways in the processing of sensory information input, which results in the misinterpretation of information. This is significant as common movements such as walking and reaching for objects can be perceptually impacted, which can cause a higher risk of falling, accidents, or general frustration from the individual. Treatments around perceptual dysfunction can include sensory stimulation, visual feedback strategies such as mirrors or scanning strategies. These treatments can aid in helping the individual understand where they are in the environment and allow them to look for any external cues. Involuntary movements are actions that can occur sporadically without conscious control and can lead to implications ranging from mild to severe impacts on activities of daily living. Key associated anatomical structures include the basal ganglia, dopamine, upper motor neurons, and the cerebellum, with each structure having a vital role in either the communication of cells and controlling movement that can be both involuntary and voluntary, the execution of the movement such as the timing, balance, coordination, and force, or inhibiting movements that may interfere with the desired movement. Neurophysiology behind involuntary movements can be caused by either imbalances of the excitability and inhibibility of neurotransmitters, disturbances in the caudal basal ganglia, thermocortical loops, dysfunction of the cerebellum, and upper motor neuron lesions. Associated conditions include Parkinson's disease, which involves the underactivation of direct pathways and the overactivation of indirect pathways, which can cause bradykinesia, resting tremors, and rigidity. These neurophysiological dysfunctions can manifest in a variety of types of involuntary movements, including dystonia, axia, tremors, troiform, and arthrotoid. In association to how it impacts motor function, patients are seen to have difficulties in completing ADLs, impairments in the walking gait and posture control, higher risk of falls, and can lack abilities in fine and gross motor tasks. Treatments aim to help individuals completing ADLs while managing symptoms with strategies such as compensation, relaxation, and adaptive equipment. Abnormal coordination patterns are linked with structures within the brain, spinal cord, or PNS, failing to properly regulate muscular activation, sequencing, timing, direction, and force, resulting in abnormal movement patterns. Key neuroanatomical structures involved in coordination patterns are the cerebellum and basal ganglia. The cerebellum acts as a conscious assessor of movement errors, fine-tunes voluntary muscle activity, and has an adaptive response to sensory input. Therefore, dysfunctions or lesions to the cerebellum can cause ataxia, leading to abnormal walking gaits, tremors, and asynergy, whereas the basal ganglia aids in motor planning, which dictates movement initiation and initiation. These implications are commonly seen in conditions such as Parkinson's disease that have a combination of effects and disruptions to coordination of movements. The neurophysiology of abnormal coordination patterns often stems from altered motor unit recruitment, impaired proprioceptive feedback, and disturbed sympathetic transmissions. These impairments impact activities of daily living such as walking, reaching for objects, postural control, and riding. In correlation to these impairments, a variety of treatments have shown to aid in improving coordination patterns. These include physical therapy training such as cycling, resistance training, coordination and balance-based exercises, as well as modified activities of daily living. In addition, video games and adaptive physical activities have shown improvements in quality of life, walking gait, and activities of daily living. Motor weakness is the reduction in normal and peak force generated by a muscle or muscle groups, with individuals having varying degree of motor weakness. Systems involved in motor function include the central nervous system, peripheral nervous system, and neuromuscular junction. Motor weakness in relation to an upper motor neuron lesion affects the lateral corporospinal tract that crosses at the medulla level, whereas for lower motor neuron lesions, damage is to the anterior horn cells or peripheral nerves. An associated condition with motor weakness is multiple sclerosis, where axons lose their protective myelin sheath, which causes neurotransmission disturbances and neurotransmitter imbalances. These can lead to symptoms of muscle weakness, spasticity, sensations of numbness or tingling, fatigue, pain, poor balance, and coordination. Motor weakness can have other various impacts on everyday life functions, as individuals may have impaired reach and grip, loss of coordination, increased risk of falling, greater fatigue, and difficulty in completing basic tasks. The treatments utilized with individuals with motor weakness may include electrical stimulation, bimanual training, task-specific, or strength training. Treatments should aim at utilizing and training the affected limb, which will aid in creating and maintaining new neurological pathways and reduce compensation. The regulation of muscle tone involves structures and interactions between the cerebellum, peripheral nerves, muscle spindles, and spinal cord. Connections between the muscle spindles and spinal cord results in signals adjusting muscle spindles, excitability, length, and tension of the muscle. Hypertonia commonly leads to either spasticity, which is the velocity-dependent increase of tone, or rigidity, which is the increased resistance to movement in both flexor and extensor muscles. Hypertonia impairments are caused by upper motor neuron lesions and commonly associated with conditions such as cerebral palsy, multiple sclerosis or Parkinson's, with impacts on motor control including reduction of quality of walking gait, limitation in joint range of motion, postural control, and chronic pain and discomfort. Hypotonia is linked with lower motor neuron lesions or cerebellar dysfunction. Impairments of hypotonia include reduction of motor muscle stiffness to lengthen, impaired reflex arc function, or loss of excitability input from the cerebellum. Common conditions include Down syndrome, spinal muscular atrophy, and peripheral nerve injuries, with impacts on motor control, increased risk of joint dislocations, and difficulty in postural control, coordination, balance. Treatment selection is dependent on the type of muscle tone associated condition. These might be modified resistance training, postural correction, and in some cases medications or surgeries.